For over 20 years, Clinics Health Group has provided world-class healthcare to underserviced communities. With every new facility we open, quality, affordability, and excellence is what we've become synonymous with. To that end, Cullinan Wellness Hospital is the latest addition to the group and the third in our growing roster of psychiatric care services. Located in Cullinan, east of Pretoria, our state-of-the-art facility is perfectly suited to service patients as far as Mpumalanga, Limpopo, and the Northwest Province in a tranquil setting surrounded by a luscious garden and mountain views.
It's very important for us to have such facilities in our communities because previously we've ignored the psychological instability. We thought we can go on with stress or depression, and because now that we have come out as psychiatric faculty to say we can offer this kind of care, treatment and rehabilitation for people who are in need of, who needs to heal emotionally or psychologically. So these kind of facilities are important to be. I would wish that every area would have this kind of wellness facilities.
I think mental health institutions and wellness centers such as this one are important mainly because we live a very rat race type of life and struggle to see when we are truly struggling with life. And being able to come into a facility like this allows one to pause and acknowledge whatever is happening in your life that is bringing you down, pause and regain function, pause and get back onto your feet in a way that you didn't even realize you needed. There's the need to have an out of your comfort zone area that will move and shake you as much as possible to get you back into a better state of you.
No matter the treatment or duration of stay at Cullinan Wellness Hospital, our patients and their loved ones can rest assured that they will be taken care of and watched over by our team of experienced mental health nurses, psychiatrists, and clinical psychologists.
Most of the patients that we admit are voluntary patients and they come on their own. The diagnosis that we normally work around is that patients with bipolar mood disorder, major depressive disorders, as well as post-traumatic stress disorders. Some has personality disorders such as gambling.
Our hospital provides private psychiatric services that aim to help the individual experience the fullness of life. We cater for a wide range of patients, including those with depression, bipolar, post-traumatic stress disorders, anxiety disorders, sleeping difficulties, neurocognitive disorders, dementia, and psychiatric conditions, amongst others.
My approach is I use what we call cognitive behavioral therapy, CBT. So basically it's helping, because most of the time I've noticed that we tend to be depressed or go into mental problems because of the channeling of our thoughts. We tend to think, if you are going through a difficult situation, you tend to think more negative about it than thinking positive about it and actually getting a solution. So I just help my patients to come up with solutions, and hence I use solution-focused therapy, because I'm confident that they do have solutions. It's just that sometimes they're not confident to put them into action.
My approach when treating a patient goes back to the good old Batupele principles. We follow a very client-centered approach. Every case is different, and so applying Batupele principles where it's about the patient, it's about dignity, it's about ensuring that the patient's needs are met, is at the core of practice, is at the core of all intervention.
As mental health practitioners, we encourage individuals to visit our facility so we can assist them in finding routine solutions to the problems they face on a day-to-day basis.
I think from a very simple point of a non-functional mind is a non-functional human. And neglecting mental health means, in essence, neglecting a whole part of yourself that is very necessary to maintain function on a day-to-day. The more we ignore the brain and the psychology and the emotions of a person as we have been, the more we are likely to not reach to the full potential that we could.
At Clinics Cullinan Wellness Hospital, we believe mental health is the cornerstone to helping you find and lead a happy, balanced life. Visit our magnificent facility at Hospital Road, Cullinan, Pretoria East. We're open 7 days a week and are ready to receive you.
Good evening, colleagues. Greetings to all of you, and thanks for taking time to tune into this weekly CHG webinar. My name is John Buchupa. I'm standing in for Dr. Raymond Biller, who is unfortunately available for this webinar this week. And I'm sure most of you are used to seeing him on this platform, but I'm sure he will join us in a week or two. We want to continue to thank Dr. Biller and his clinical team and the marketing team who have been running this series of webinars since the middle of the lockdown, really. Colleagues, this webinar is recorded and will be made available to all of us via a YouTube link, which will really allow you to listen to it once more at your own leisure. A humble reminder, the webinar is registered with the Health Professional Council and is CPD accredited. By providing your full credentials when you register, these credentials will be automatically sent to the Health Professional Council or the council you are affiliated to. A few ground rules, colleagues. Our speaker, Dr. Chivaugn Gordon, is working on a tight schedule. We only have her up to 7 o'clock, and that will include her presentation and a Q&A session. Once more, the speaker will be introduced and allowed to complete her presentation, and a follow-up Q&A section will therefore follow after. We are allowed to send questions in the chat box, which will be read at the end of a presentation. We humbly request that all microphones are muted and the video functionalities are disabled, as this tends to disturb the network. We humbly request that you take time to complete the follow-up survey, which will be sent to you as a link. This survey assists us at clinics to improve the service offering on this platform. Colleagues, you are once more also welcome to suggest topics or even volunteer to be speakers on this platform in whatever field that you may be coming from, be it pharmacy, nursing, healthcare management, sports medicine. And we also know that there are practices that are involved in research, which may need to bring on any presentations on this platform. And all communication can be sent to either the clinical team or the marketing team. Without further ado, colleagues, it gives me great pleasure to introduce Dr. Chivaugn Gordon. She is the head of undergraduate Ops and Gynae education at the University of Cape Town. Her alma mater, really, where she did her MBCHB in 2003. completed a diploma in mental health and HIV medicine. She holds a master's of philosophy in health professions education from Stellenbosch. During her time as a medical officer, she spent a lot of time in the psychiatry department, wherein she developed a keen interest in intimate partner violence, which will be the topic of our discussion today. She developed key components of the intimate partner violence curriculum for medical students through her research program. Dr. Gordon boasts numerous University of Cape Town and national awards for her work. And she also shares a lot of opinion pieces in the Sunday Times and the Daily Maverick. Ladies and gentlemen, allow me, to welcome for the presentation, Dr. Gordon. The stage is yours. Thank you.
Thank you so much. And it looks like somebody's having a birthday. All the balloons. Is it your birthday?
Indeed it is, Dr. Gordon.
Happy birthday.
Thank you very much. Thank you.
And here you are stuck in a webinar. Well, hopefully it'll be worthwhile. Thank you so much for the introduction. Yeah, here's the topic. And it's obviously a very important one. And as we are embarking on this discussion tonight, I do have to issue a trigger warning because given the burden of intimate partner violence that we have in our country, it's highly likely that there are victims or survivors of IPV in the audience, and it's equally likely that there are perpetrators of IPV in the audience. So I need you just to keep that in mind if you are asking questions, just to be sensitive to that fact. Okay. There's been a lot in the news, a lot of women who are being murdered by their partners. And this talk is going to think about IPV as a whole, but we're going to be spending a lot of time talking about intimate femicide because that is the ultimate outcome of intimate partner violence. And, this has been going on since time immemorial. We often only hear about it when it's, famous rich white people, and yet it's happening on the streets every single day. I'm going to play you a little video of something that I did with my students to show you just how much of a problem this is compared to other, common clinical disorders. Prevalence of breast cancer is 4%, which means that 2 people in 50 would get this condition during the course of their lifetime. The prevalence of diabetes mellitus is about 10%, which means that about 5 people would get this condition during their lifetime. The prevalence of HIV is 14%, which means that about 7 people during the course of their lifetime would contract HIV and be living with it. And the prevalence of hypertension is 26%, which means that about 13 people in 50 would be diagnosed with this during the course of their lifetime. So those are all conditions that we know are common. When you look at intimate partner violence, the prevalence of IPV is 36%, which means that a staggering 18 women in 50 will be affected during the course of their lifetime. It is clearly a massive problem. And even if we ourselves are not experiencing it, it does affect us all in one way or another and in ways that we cannot even imagine. Intimate partner violence is clearly a massive issue that we do not often think of as a healthcare problem, the way we conceptualize other healthcare problems that affect individuals and societies, whereas in fact it is a healthcare problem. It has massive consequences and impacts on just about every other medical condition you can think of. Okay, so you're starting to get the idea of the gravity and how enormous this problem is. Another way to look at it is there have been statistical sort of modeling and looking at the prevalence of IPV, and what is thought is that of all the violence in our extremely violent country, everything, gang violence, hijackings, robberies, everything, it's thought that about 2/3 of all of that violence is in fact intimate partner violence. So it's a huge problem. Here's a slightly more medical way to look at it. We know what the maternal mortality rate is, which is about 3 to 4 women die a day from obstetric causes. And the intimate femicide rate is exactly the same.
which gives us the highest intimate femicide rate in the entire world. So it's really important that everybody who has the opportunity to deal with this issue knows what to do. Now, intimate partner violence is one form of gender-based violence. GBV is the term used to capture violence that occurs as the result of the normative role expectations associated with each gender. That's assuming that there are only two genders, and obviously there's a lot of debate about that at the moment. But yes, there are certain roles that women traditionally fulfill and that men traditionally fulfill, and there's often an unequal power relationship between those roles and who has to perform those roles. And gender-based violence is very definitely rooted in a specific context in a society that has its cultural norms and expectations. So lots of different types of GBV exist, and we are focusing today on this one particular kind. So we're going to talk today about some definitions. You're going to understand what the risk factors for an intimate femicide are and why you should really care about this topic as a healthcare provider, and understand what your role is in preventing an intimate femicide. Now, in 1999, a really revolutionary piece of legislation was written, the Domestic Violence Act. And in it, it encompassed a whole range of different types of intimate partner violence. Everybody knows about physical violence, which is ironic because it's the least common manifestation. We're going to come back to that. These other things are all they are written into the Domestic Violence Act of 1999. So you can see there's things here that you might not ever have known about. Damage to property. So if the perpetrator damages a victim's property, that is a form of IPV. If you enter the victim's residence without consent, that is a form of IPV. Any kind of harassment or intimidation, or in fact, any other controlling or abusive behavior. So it was a pretty comprehensive act at the time, and there's been a revision since then, which I will share with you a little bit later. It's really important to understand that where there's perpetration of IPV, the perpetrator wants to control the victim. That is the main motivation. They believe that it is absolutely their right to do so, and that they are sexually entitled to that victim, which means basically, if I want to have sex with you, I want to have sex with you, you can't say no. It can happen to women or men. It's very difficult to get statistics about men because it's something difficult enough for women to be able to talk about, but the sort of stigma and the shame that goes with men experiencing this is enormous. So it's difficult to know how big the problem really is. And it can happen in heterosexual or homosexual couples, or any kind of gender spectrum. Now, a lot of people have the misconception that it's only going to be, your uneducated, economically dependent woman who's at risk of IPV. And in fact, there is some truth to that. So if you live in a rural area, you are more likely to be a victim of intimate partner violence. And that does have to do with, education opportunities, economic opportunities, and all of those things that go together. But every time I run this workshop for my medical students who in one way or another are privileged, I mean, they are students at UCT, they got there, there's, obviously there's a range, but they're educated, they're at the most expensive university in the country. Every time I run this, which is 10 times a year, there'll be a student who comes to me. I'm in an abusive relationship, what can I do? And I've known judges and lawyers and, so a really key message is that you can never make an assumption about the woman sitting opposite you in terms of whether she's likely to be in an abusive relationship or not, based on what she looks like and what she does. Really important is the fact that 50% of perpetrators also directly abuse the children, which sets up a horrendous intergenerational cycle, because abused children are far more likely to become perpetrators or victims of IPV in future. And we also know that women who are abused by their male partners are more likely to be abusive towards their children, because it's kind of the culture of the household. The tone is set by the more dominant partner. So multiple issues, and it bleeds into the next generation. So ideally, in an ideal blue sky world, we should be asking at least every woman about domestic violence. Sorry, someone's mic is on. Can everybody just check that their mics are off? Okay. Whose mic is on? I'm going to, I don't know. Someone's, okay, hopefully it's off now. Sorry, it's a bit distracting. Okay, so the ideal is that we should be asking everyone, because if we were sitting in a room, I would pick on you and ask you to tell me what you think that 9% statistic represents, but I can't pick on you, so I'm going to tell you. 9% of the time is how often there is physical evidence of profound intimate partner violence that is happening at home. Because IPV manifests in a lot of different ways, which is why I'm glad that there's a whole lot of different disciplines sitting here tonight. So if we don't ask, especially when we need to ask, and I'm going to show you what are those red flags that should prompt you to ask. If we don't ask because we have the assumption that everybody who is in an abusive relationship will have some physical evidence, you're waiting to find the black eye or the broken arm or the whatever, we are going to miss 90% of cases. And the reason for that is that IPV is a psychological crime, which uses all kinds of different methods and behaviors to control the victim, and usually or often physical violence is the last resort. And actually you could be in a profoundly abusive relationship and the perpetrator never has to lay a hand on you, because psychological abuse is extremely damaging. Victims talk about it being far worse than any physical injuries. So IPV is about control. I've said it before, the perpetrator wants to control the victim. The specific term for this behavior is called coercive control. And what is coercive control? Well, it is a type of intimate partner violence that you can't really see. And it's a pattern of behaviors designed to be able to control the victim by slowly, drip by drip, just eroding that person's self-esteem and their autonomy and their ability to make decisions. And it includes intimidation, it includes threats, it includes humiliation, gaslighting, and it's very closely linked to future intimate femicide. So some examples of this kind of behavior are, checking up the victim's cell phone all the time. Is she communicating with anyone I don't want her to communicate with? Taking control of all the finances, cutting her off from her family so that she's isolated, which means where's she going to go if she wants to leave? Insults, humiliation in public to just totally degrade this person and their self-esteem. Threats, intimidation, and that's threats not only to the victim, but threats to her family members, threats to the children, threats to the pets, threats of damage to property, anything, any kind of threat that you can make. And also sexual coercion or not respecting, if somebody in a relationship doesn't have the ability to say no to sex, that's a huge problem, okay? And there's probably some kind of coercive control going on. Which is why the revised Domestic Violence Act is so brilliant, and it brings a whole new dawn for people who understand what IPV is really about. They have written in all of these sorts of behind closed doors behaviors that don't give you a black eye or a broken anything, but are profoundly abusive and controlling, and therefore have a link to intimate femicide. So you can see all the kinds of things that are included there. So the types of abuse that people experience have much more inclusively been now put into the revised DVA. Now, obviously, women don't report. Men don't report either, but I work in women's health, so I'm talking to you about women. And there's a lot of reasons for that. We have multiple different cultures in this country, and different cultures view different types of abuse in different ways, and perhaps some are acceptable and others are not. Victims are often economically dependent, totally isolated from their families, or they don't know where to go, or there's systemic failures. But probably the most compelling reason is that they are absolutely, desperately afraid of what their partner will do to them or their children, if they are children, if they report. And the best description I've heard of IPV is intimate terrorism. And that is what victims of abuse are experiencing every single day. They are living in absolute fear, waiting for the next explosion, the next argument, the next round of humiliation, the next jealous rage, and yes, the next, physical violence, whatever forms these may take. And that obviously has a huge effect on you as a person when you are living under such horrendous circumstances. So now, what is your role as a healthcare provider? Well, I don't think it's practical to universally screen, much as that should be the gold standard because of our burden of gender-based violence and IPV. Practically, we might not have time to do that. And I'm going to show you what the red flags are that should prompt you in this particular patient sitting in front of you to actually enter into that conversation. I don't have the expectation that you must do it with everyone, but with these things, you should ask. So there's my cat. Her name is Maz. Pink is my favorite color. So obviously I've got pink Christmas decorations. That's Maz in a normal consultation. And this is Maz. She's picked up a red flag. Something in this consultation has made her think about intimate partner violence. I'm going to teach you what those things are. I wrote an article some years back, and I gave a framework for how to approach identifying and managing IPV. It's called the 6 R's. Oh, let me put my video on so you can see me if you want to see me. The 6 R's is, number one, realize that the abuse is happening. And if somebody discloses abuse to you, then recognize and acknowledge what they have said. We cannot dismiss what has been said. You need to do a relevant clinical assessment. Very important is the risk assessment. That is assessing the risk of an intimate femicide. You might need to give some input on a crisis plan, and then your ultimate aim with your patient is to refer. And the most important ones that I expect healthcare workers to be able to do is to realize, do a risk assessment, and refer. Okay, the end game is referral, because no number of webinars is going to adequately prepare you for this. Okay, so what would give you the sort of red flag to think that somebody might be being abused? Well, how do women who are being abused present? If you look generally, all the chronic pain syndromes, because that's a type of somatization of psychological distress. Poorly controlled chronic conditions is a big one, and there's a lot of reasons for that. So number one, your partner might be denying you the finances to get the taxi or whatever to get to the clinic, to get your chronic meds. Or you could be so profoundly depressed and miserable that you actually really don't even want to be alive. So why would you want to take your antihypertensive? Okay, so if you've got people where it's just, you just cannot get on top of their chronic illness, think a bit more what's happening at home. You are obviously not going to be able to function very well as a parent or an employee or a family member if you are living under the conditions of intimate terrorism. And we do sometimes have patients who they don't know how to express it. They don't know how to tell it. They want the help, but they don't know how to get the help. So they've got these vague, like non-anatomical, weird things that make no sense to you as a clinical person, but it's an expression of I need help. And sometimes you just get a feeling. You get a feeling, you can't put your finger on it. Remember that your subliminal brain is making connections like millions of times faster than your conscious mind is. And sometimes, your subliminal subconscious mind might have perceived something that your conscious mind hasn't yet noticed. So don't ignore that kind of gut feeling. Now, this is going to be a huge route of entry because you are living under the conditions of intimate terrorism and your life is awful and you are constantly terrified. And I watched the video about your unit that offers psychiatric care, and I very much hope that everyone is asked about what's happening at home, which obviously they should be in this context. But, depression, serious anxiety, PTSD symptoms, you could be self-medicating with substances, you could be self-harming or suicide attempts because your life is so awful that you just actually don't want to go on. So in these circumstances, I would expect the clinician to ask about intimate partner violence for obvious reasons. And then in gynae, which is where I'm based, yes, anyone can have one STI, you can have a discharge and it's treated and whatever. But if you're going to come back again and again, then I want to know, what is the dynamic between you and your partner? Was it that you were incorrectly treated for your STIs? Was it that you didn't get a partner notification letter? Or is it that your partner is refusing to be treated, refusing to use condoms? How much agency is there in your reproductive health? Any kind of sexual dysfunction, so for example, vaginismus, which is a very painful tightening of the pelvic muscles when a woman when penetration is attempted, that can be related to psychological distress. Chronic pelvic pain as well. Now, the sexual dysfunction and chronic pelvic pain are often related to previous rapes. And remember that rape and sexual assault can happen in an intimate relationship. Okay, so it's also something to think about. It might have been some other sexual assault or rape, but it could be within the relationship. There is a direct link between IPV and HIV because the sex is more violent and it causes more tissue damage in the vaginal mucosa, which makes HIV it easier for HIV to get into the system. There's an increase in need for termination of pregnancy. There's an increased incidence of miscarriage as well. These women struggle with reproductive autonomy, and perpetrators are much more likely to have multiple partners, which confers sexually transmitted infection risk. And if we look at obstetrics, pregnancy is an extremely high risk time. And the mechanism for that is that if you've got an extremely controlling and jealous partner, a woman's attention when she's pregnant, it kind of shifts from the partner to the baby. That's normal. That's, adaptive behavior. But if you've got an extremely jealous partner, he's not okay with your attention drifting from him to the baby. So these perpetrators can sometimes attack the pregnancy physically. So pregnancy might be, there's been psychological abuse all along, and now suddenly the physical abuse starts manifesting. So if you ever see a patient who's got an abruption, yes, it's most likely to be due to gestational proteinuria hypertension, but you do need to ask about violence. The same thing with miscarriages as well. We also know that pregnant women who are being abused have less uptake of the services that they and their babies need. They tend to have more children. They tend to have more unplanned and unwanted pregnancies, hence the need for TOPs. And that is because their bodies are essentially being controlled by the perpetrators. So they often lack any kind of reproductive autonomy. So that's how far that controlling behavior extends. Of course, there are going to be injuries and things to make you think about IPV, because people fall over, you get injured anyway. But if you've got someone who's got just repeated injuries, they've got a casualty folder that's this thick and every month it's a different injury. I mean, what's going on there? Or if the description of how, I walked into a cupboard, that's going to look very different to being, physically punched in the face. So if it doesn't match, then you need to think about asking. Please, if you work with children and you've got a child who either has behavioral issues at school or academic issues where they were previously performing okay, or if you think that the child is being emotionally or physically abused, the next person you need to think about is the mother. Because those kinds of situations, those types of behaviors in children often relate to abuse happening in the home. And remember, I said that 50% of the perpetrators of violence to the woman are going to perpetrate violence against the child as well. And the woman herself is also more likely to perpetrate the violence. So you have to make that link between a child who's in distress and you have a suspicion and what could be happening with the mother. Now, this is often what gives you the little ping subconscious thing that makes you think again. There's something about how the patient is behaving. When patients come to us, most of them cannot wait to tell us every single thing that's ever happened to them since they were born. So if you've got someone sitting opposite you who's reluctant to engage, they're very anxious, they're not making eye contact, they're sitting in a very sort of defensive, closed off kind of a way, that's not normal behavior. So what's going on? Sometimes patients can be verbally aggressive, and the mechanism for that is perhaps at last in you they see a safe space. And so 10 years of suppressed emotions, of having to be under control yourself so that you don't cause something to happen in your partner, just all of that emotion just bubbles out. Okay, and that's not to say that anything that the victim does can justify the perpetrator's behavior. Absolutely not. Okay, so here's some examples of patient behavior. So the woman in the top left, I mean, maybe she's just been sitting in the grootste queue for 12 hours waiting to be seen, and she's a bit passive aggressive, but she's definitely defensive. The one in the top right, she's closed off, arms crossed, legs crossed. Patients don't normally sit like that. And the woman at the bottom just looks a little bit sad. So what's going on? And this is a big one. Partners. Remember, I've said that the partner's desire is to control. And that often extends into a medical consultation. They want to control the narrative. They want to make sure that this person's not going to leak anything to you about what's happening at home. Most of them are quite confident with their intimidation and their threats that their partner is not going to disclose. So fine, the woman comes in on her own. But you get partners who come in who will not let that woman speak for herself. And that is something that you as the doctor cannot allow. So if a partner comes in with the woman, and this could be a woman partner as well, but partner comes in, you create the rapport and you listen to everybody's side of the story. It's going to be the partner who's telling the whole story. And then you say, okay, it's time for me to examine the patient now. Would you mind waiting outside? Usually that works because remember, you as the doctor are the person with the most power in the room. I don't mean to say that in a way that you should abuse your power, but as doctors, we automatically, and nurses, all healthcare practitioners actually, you're the one with the knowledge. You're the one in the room who's going to help the patient. So you are the one with the most leverage in the room. So usually the partner will respond to that because they don't want to take on, you. But if the partner doesn't want to leave, that's even more of a red flag. And I've had one situation where that happened, and I admitted the patient, not because she had a medical indication, but because I could see that this was a seriously controlling partner, and I needed to find out what was happening to this woman. And sometimes you just get a gut feeling. I think that's what the appendix is for. I mean, it's got no other function. Gut feeling, something's not right. That's, again, you've perceived something in your interaction with this patient, and don't ignore that feeling. So if you think your patient is being abused based on her clinical presentation or her behavior or her partner's behavior, what are you going to do? Because that's the crux of the matter. What are you actually going to do? Because no one's taught you how to do this before. I know that because I've done the curriculum mapping, and we weren't even doing it at UCT. Your job is to identify, do the risk assessment, and refer. Okay, your end game is referral. I do not expect you to manage these cases. They are incredibly complex. Okay. The first step is that you actually do have to ask. So if there's a suspicion, you need to ask. A lot of doctors don't ask because they think it's inappropriate or it's intrusive or that's their private matter. Well, actually, no. Women appreciate being asked, even if they're not being abused, provided that you ask it in a sensitive way. And women who are experiencing such profound abuse are so desperately waiting for someone to ask the question. They don't know how to report, or they're too scared to report. And they need you to ask them so that they have legitimate grounds to actually carry on the conversation. And I can guarantee you that if you haven't had training like this, no one else, if you haven't had the training, no one's going to ask. You probably haven't been asking, not because you're not willing or you don't realize, but because you haven't been trained how to do it. So those of us who know a bit more, we have to ask. Okay, so how? You got to start broad. You can't just dive in and say, is your partner abusing you? Because, whoa, that's going to throw her a bit off balance. And as much as she's wanted to hear that question, nobody in the last 10 years has asked her. So it's going to take her by surprise. So you start big. Is everything okay at home? Are you in a relationship? And a good way to phrase a question to get an accurate answer is, instead of asking, are you happy in your relationship? It's very easy to just nod, yeah, no problems. If you ask, are you unhappy in your relationship? That forces the patient to think about whether they're going to disclose something that's uncomfortable to you. And you can see a lot in those couple of seconds while they're thinking about it, the body language, you can determine a lot. So you're much more likely to get a truthful answer than if you just say, are you happy at home? Is everything fine? It's very useful to normalize, because then that woman doesn't feel like she's the only person in the world experiencing this. So you can say, I'm going to ask you something that I ask everyone because it's so common in our country. And, you know, for me, the last one, you know, in a tertiary gynae clinic, we often see really complicated cases of chronic pelvic pain. And so then I'll say, you know, often when I see patients with this kind of problem, it might not be due to something that's actually in the pelvis. There might be something else influencing it. So you can phrase it, you know, in any one of these ways. It depends on the context. A nice, easy one to remember is the one where you normalize it and say, look, I ask everybody this because women know how bad the situation is in our country. So if your patient confides that she is being abused, what are you going to do next? Your job is to empower her. Okay? That's what I want you to imprint on your brain. Hopefully, before you ask the question, you need to have established a good rapport, and you need to assure her of confidentiality. If she discloses abuse, you have to acknowledge it. You cannot just dismiss it. And it's very powerful to hear from a healthcare provider that this abuse is not acceptable. It's a criminal offense, and you are not to blame. Okay? Don't ever invalidate what is said, and we cannot impose our own cultural frame of reference, because the frame of reference is the Domestic Violence Act. Okay. Yeah, we're going to go on to like specific things to ask for the risk assessment. Now, equally important to the patient's body language is your body language. This is an incredibly sensitive thing to disclose. And so if you're going to be sitting like this or tapping your foot or checking your phone, you don't create that rapport in that environment. So here we've got some situations. Okay, top left, that woman in the hospital bed looks like she's having the best day of her whole life because the doctor's sitting at like 45 degrees to her. And the one on the top right, I mean, she looks like she's about 12, but she's very open and, you know, she looks like she's interested. And the guy at the bottom, he looks like a little bit constipated, but he's listening, he's open, he's paying attention. So your body language is important in this situation. Now, the patient hasn't come into your office to say, I'm being abused by my partner, okay? They've come in with something else. They've come in with the PID, or it's their second TOP, or, you know, they're suicidally depressed or whatever. So if you've identified that there is intimate partner violence going on, there might be other things that you need to look at. And probably the most common thing is a psychiatric assessment specifically for suicidality. You know, maybe she's come in for an STI and you identify, you know, really serious IPV. Well, what is her mental state? Okay, risk assessment. Now, this is where we come to some specific questions. You could ask millions of questions about all the different types of IPV that there are, but where you've got limited time, you want to identify the women who are most in need of help. And that is through your risk assessment, okay? The following questions. If the woman fears for her life, you ignore that at her peril. She's got a reason to fear for her life. Don't ignore that. If she's being threatened with serious harm, or the children, or in fact, any close family members are being threatened with serious harm, we cannot ignore that, because 50% of the time, the perpetrator will follow through, and we don't know which 50%. Okay, so serious. If the children are either being directly abused or they are witnessing the abuse, that shows you the lengths to which the perpetrator is prepared to go in perpetrating their violence. They're not even protecting the children. They're not even doing, you know, abusing their partner behind closed doors, or else they are directly abusing the children. That is an extreme indication of violence. So it's linked to a risk of intimate femicide. If the abuse is escalating, so it was psychological, now it's become physical, or the episodes are becoming more frequent or more intense, the ultimate escalation is intimate femicide. A weapon, particularly guns, that's extremely dangerous, but a weapon is a knife. It's a lampshade that I hit you on the head with. It's any kind of object that's being used to cause physical harm. If the partner's on substances, there are no brakes on that vehicle when the substances are in the body. Then the violence just bubbles over. There's nothing holding them back. Very dangerous. If the partner, the perpetrator, has ever tried to throttle or strangulate the victim, that confers a 7-fold increase in femicide risk. Very dangerous. If that partner is stalking the woman, and that's often the case if a relationship is ended, if the partner is stalking, following you everywhere, you know, in your inbox, in your WhatsApps, everywhere, all the time, very dangerous, because that is, if I can't have you, no one can. Same with excessive jealousy. And if there are any coercively controlling behaviors, like the monitoring, like the isolation, the humiliation, those kind of things, threats, intimidation, those are all risks of an intimate femicide. Now, a crisis plan is something that we do for women who are wanting and ready to leave their abusive relationships. But there's a big thunderbolt there, because it's got to be if she's ready. And in fact, you as the healthcare provider are not best placed to talk this through with someone, because leaving is the most dangerous time, okay? Lebo Monene was shot to death by her partner, who was a police officer, had access to a weapon. He would threaten to shoot her if she left, and then she left, and he did shoot her. So you can never instruct a victim of abuse to leave their relationship, because leaving is the highest risk time in the entire history of this relationship. 75% of intimate femicides occur during the first 3 months after either saying I'm going to leave or actually leaving. Okay. So you cannot do that without a lot of planning, a lot of, money put aside, help from an NGO, a place to go, all those sorts of things. And also if she leaves because you told her to, I mean, if the perpetrator knows where to find you, you're at risk as well. So you need to give her options to help her choose and tell her that you're going to respect whatever she does. And your mission in doing the risk assessment, you already know that she's at risk if she leaves, but the risk assessment demonstrates to her that she's at risk of further harm or femicide if she stays. And that is a horrible decision to have to make, but it's got to be an informed decision, and it's got to be her decision with the help of an NGO, which is why you need to refer. So the first prize is you refer her to an NGO whose everyday business is intimate partner violence. They will pull in the whole multidisciplinary team. They'll help her think about what her next steps are going to be, and they'll help make the best decision for her. So that is your first prize. There are a lot of emergency shelters, certainly in Cape Town, and nationally there would be as well in the major centers. So if a woman, for example, does want to leave and she wants to leave right now, she's in a huge risk, then she can go to a shelter. But also important is not, referrals within the system, but getting people back into her life. So her family, are there, refer her to information on the web. Are there community institutions, religious institutions? You need people to help her, especially if she's going to leave. She's going to need help to do that. Social workers can be very helpful in the hospital setting. In an outpatient setting, it's more difficult because their caseloads are enormous. So social worker might not really be able to get to that patient. So an NGO is usually the best. Sometimes you need a medical specialist. Someone's suicidally depressed, or they've got severe PTSD, or they've got a severe fracture or whatever, that you might need a medical specialist. And legal assistance is available, but that is something that the NGO can take the patient through. Okay, I wouldn't expect you to be able to do that. And if she ticks everything on that risk assessment list, then she might need an urgent referral to a shelter, or she might need admission. And whatever your setting is, I don't know if you'd be able to do that or convince other people that you need to do that, but that is certainly what I would do. Okay. Keep going. Why is it stuck? Okay. So in conclusion, and we can go a little bit over 7 because my baby's not beating down the door yet. IPV is a silent epidemic. If you've been looking at the news, you have some idea of how big the problem is. I hope I've shown you today that it's really huge. And it's a healthcare problem because it affects so many different areas of healthcare. And I think one of my slides disappeared. What I also want you to understand is that when victims are going to disclose, they disclose to the healthcare practitioner, not the police, because the police is another story. They don't go to a court, they disclose to us. So we are the ones who have to be ready to ask the questions and deal with the answers. IPV is potentially absolutely deadly. Okay, not every woman who is in an abusive situation is at risk of femicide, but we do have the highest femicide rate in the world. Massive far-reaching effects. It goes from generation to generation to generation. And you could quite literally save this woman's life by opening up the conversation, particularly because there's so few people out there who are trained to do this. And so few people are going to be asking the questions. And your main aim is to be able to identify. So think about the situation, the person opposite you, are there any red flags? Assess the risk of femicide and refer. And I don't expect you to screen everyone. So you really need to know what the situations are where you must ask. And your role is to empower this woman to make the next decision for herself. We cannot make the decision for her because we are not her. We don't fully understand what is happening in her household. And if we start trying to make these kinds of decisions for her, we further disempower her. So, you know, we don't want to secondarily traumatize our patients. We want to start the process of empowerment in that consultation. And here are some NGOs that you can contact. There are many. I mean, you could just Google, you know, places near you. And even in the rural areas. So the NGOs that I went to talk to when I was deciding what to teach my medical students, I said, you know, I was in the middle of Limpopo for my ComServe. Where would I send a victim in that case? And she said, look, the NGOs said, there's usually a gogo or an auntie somewhere and who's got a safe house, and your job is to just find out from someone, maybe the nurses will know or whatever, find out where that safe house is and make use of it. And, you know, I could talk about this for many, many, many more hours, but I'm going to stop there.
Thank you very much, Dr. Gordon. A very insightful presentation indeed. And I think a presentation that, you know, touches many of us, obviously as practitioners. We are often, you know, the first, you know, point of call when, you know, you are faced with obviously people that have suffered intimate partner violence. You mentioned quite a lot of interesting, you know, approaches to this subject. And you've often said that sometimes the signs are there and some signs, they might be silent, but I think I would speak for many practitioners when I say some of the signs are actually very obvious to most of us. And many a times patients walk into our rooms with J88, you know, forms from the police station, and we are left obviously with the burden of, you know, completing, you know, the forms and treating the patient with whatever ailment they might be presenting with. But the burden still remains the referral route, and how do you then move as a practitioner, you know, to try and assist, you know, this patient, and how do you best intervene? And things like, you know, partners that are, you know, possessive, as you said, partners entering the space in your consultation room, often don't make things easy. So I cannot imagine that it's an easy subject, and I'm sure I speak for many practitioners. But having said that, I think maybe let me take this time to go through the chat box to see what other you know, colleagues are asking. The first question comes from Dr. Thabo Mashego. He's a regular on this platform, and he's asking, because of shame and stigma, can you please give us a brief overview of male victim IPV?
Yeah, sure. So, I mean, males experiencing IPV isn't my primary area of expertise, but what I can tell you is that, look, remember, most IPV is psychological, and that's across the board. So you'll often find that when a male is a victim of IPV, it is on the basis of psychological abuse. So the humiliation, the degradation, you know, the shouting and screaming, the insults, those things that, you know, people might just say, oh, you know, they argue a lot or whatever. But so a lot of male IPV is to be found in the psychological realm, the verbal abuse, the emotional abuse. And it can be financial abuse as well. And it can also be physical. It's often not physical because just of the usual difference in size and strength of male versus female partners most of the time. But certainly, you know, males can experience a lot of just complete and utter destruction of their self-esteem through a verbally and emotionally abusive partner, which could be male or could be female. So again, it's going to be less about the physical things than about how that person is made to feel inside. And how is that going to manifest? Well, if it's going to manifest at all, it's probably going to be in the realm of psychiatry. It's going to be depressed. I'm not functioning at work. You know, I have sexual dysfunction. So that's, I think, where, you know, anybody who's got a psychiatric problem, having worked in psychiatry myself, part of what you're asking has got to be, what are the home circumstances? What's happening in your relationship? And that's true for men as well as women. So you can apply all of those, you know, controlling behaviors can also be perpetrated against men, and probably less so the physical violence.
Thank you very much, Doctor. The second question comes from Dr. Martha Ledwaba. She's asking, how do you empower or assist a dehumanized, physical abused woman who wants to get a protection order from the SAPS, but afraid of secondary victimization by the very SAPS members? Because I think, once again, this is also a very common finding that we are confronted with.
Absolutely. So thanks, Martha, for that question. It's a very good question. In fact, so I didn't go into the legalities with you, but if a victim wants to get a protection order, they do not go to SAPS. They go to a magistrate's court, which is, it can still be an intimidating environment, but if you go to a magistrate's court and you say that you're there because you want to take out a protection order, you will get routed to a clerk who is specifically there for the purpose of helping people with their protection orders. You will be assigned legal representation and they will take you through the process. And I think this was specifically done precisely because people working, and this is long before my time, but people working in domestic violence and IPV could see very clearly that, you know, the cops are a huge problem, because you go there and you want to report it, but the cop is your partner's drinking buddy, or, you know, the cop's a perpetrator as well, or whatever. So they've taken that process completely away from the police. The only time you would go to the police is, and that's another one of the problems, is that I've told you that IPV is a psychological problem. But you cannot go to the police and report coercive control or monitoring or whatever. You can report physical abuse, you can report rape, you can report damage to property, but that's a small, very small percentage of what IPV actually is. Whereas a protection order caters for every single type of abuse that is listed in the Domestic Violence Act. So in fact, the system is not as bad as you've thought it is, Martha. It's got nothing to do with the cops. It's a magistrate's court. It's a specifically trained judge. And that's how it works. It's not perfect by any means, but that's how the system works. No police involved in getting a protection order. And of course, the best way to empower a dehumanized victim is to be empathetic and listen to the story and assure them that you're going to help them to the best of your ability. That's all you can do as the clinician, but I'm telling you right now, that's a huge amount because of your position in the community.
Thank you. Sorry for cutting you short. I was saying, Dr. Dibani is also asking yet another question around male victim IPV, but I think his question is loaded. It's very extensive. Perhaps maybe if you would allow me, I would ask Dr. Dibani to come on and unmute himself so that he can ask this question as it appears more like a comment or anything. Dr. Chivaugn, are you able to come on?
Oh yeah, for sure. Thank you very much, Program Director. Yes, I can make a comment if you do allow me to do so. Okay, thank you very much. I think that there's a challenge currently that we are facing, especially as male partners. I think in this against the turn of things and what have you, I think the male IPV the IPV where males become victims, I think it's gaining so much momentum in many of the families nowadays. And certainly I even think that when we speak of GBV, we perhaps need to now include men, because there's really serious challenges that men is facing out there. One of the things I wanted to check is, say you are in that toxic relationship where all those symptoms that you spoke about, Dr. Gordon, in terms of shouting and maybe issues of money, finances, and what have you, how then do you disconnect yourself as a man or as a male counterpart in such a situation? Unfortunately, what then becomes a problem, you think about the children, say maybe you've got 1 or 2 children with a spouse, and then the empathy for the children sometimes overwhelms you, that you continue in that toxic relationship that is really not helping you as a human being. Then my question is, how do you deal with that? And at the back of your mind, also think of the stigma that is there. In our society, still not fully acceptable that a man, you are being abused. It's, I don't know, a few members or not so many people in the society will accept or will sort of like regard you as a man, things like those. So how then do you really deal with that? I don't know whether I've managed to put it clear. John, you'll pardon me if I haven't. Thank you.
Yeah, I think I understand what you mean, that there is a precedent and perhaps a clearer pathway for women victims of abuse to get help to perhaps think about leaving a relationship like that. There are specific, NGOs that you can go to. And I totally acknowledge what you're saying, is that we don't in any way, shape or form have something like that for men yet. And I think you're right. I think the pendulum has swung so far, and I think it's had to happen out of necessity. And it's going to take quite some time for it to kind of even out and be more, centered. So, I mean, if I were to put myself in the shoes of a male partner like that, and in fact, I do have a family member who is, a male and experiences horrific emotional abuse at the hands of his female partner. I think what's available to help that person would be a slightly different system. I think that whoever you are, if you are in a relationship that is destroying your soul, whether there are children or not, nobody should have to feel like that. And, then perhaps efforts need to be made to think about getting out of that relationship. And I think the thing that would support men to do that, where it's a bit more private and there's a bit less stigma, would be to enter into a therapeutic relationship with, for example, a psychologist, not to help deal with the trauma, but also to kind of help you find the strength to decide what your next steps are going to be. So basically, the psychologist would be the proxy for an NGO system for a woman. That's the best I can think of for now, and it's totally inadequate. I hear that, and it doesn't help people in the community who don't have access to that kind of support in terms of therapy or psychology. So your point is taken, but yeah, please, I don't think that anybody, just because I'm an advocate for women doesn't mean that I don't recognize that men also suffer in these situations, and no one should have to suffer like that. And to stay in a relationship with the children is probably the worst thing you can do, because the children are aware of everything that is going on, and they can feel it, they can sense it, and it impacts on them as well. And probably it will be much healthier for everybody if that toxicity is just broken and you start again.
Well said, Dr. Gordon. I can't agree with you, more than what you've said, especially when you look at, the concept of male ego. I think it somehow also plays a role as well. In fact, you are more likely to see a male patient at the extreme of the spectrum, when, your patient has now hit, full-blown major depression, and it actually started out as an IPV. Going back to the chat box once more, Dr. Edwaba is also asking any role, for the political system. What has been your experiences in your part of the world? Are politicians willing to come on board? Government, municipalities helping? Because this is really a growing kind of.
It is. Oh God, kunzima, ne? My experience is very cynical. My experience is that the politicians will want to come to a nice webinar and put that on their CV, and then say, yes, I'm going to do this and we're going to do that, and then nothing actionable seems to happen. Part of the problem is that there are so many roots of intimate partner violence. It's not like if you fix the policing system, it's going to,
somebody's mic is on.
Yeah, someone's mic is on. So I think that remains the biggest challenge, is that it's such a multifactorial problem. It's the patriarchy, it's the living conditions, it's the legacy of apartheid and the violence that we've inherited from that. It's economic opportunities. There's so many things that my cynicism is tempered a little bit with, like, God, how would I deal with all this? I don't know. And that's why I don't sit and wait for the politicians. I have got a toolkit that I can use to help the one person who's sitting in front of me, and the next person who's sitting in front of me, and the next person. Because if I start thinking about all the failures of government and the lack of, commitment and things happening, I'll stop. I just won't be able to go on. But I think the one thing that's really encouraging is that we've had the Amendment Act, which shows a political willingness to understand that there are so many more subtleties about intimate partner violence than were represented in the previous act. So our act is one of the leading acts in the world. The 1999 one was, and the current amended act is really, it's a massive, there's very few other countries who've included all of those psychological forms of abuse. So I think that we are starting very slowly to move in the right direction. But I don't think that we as individuals have to wait for that or should wait for that. We must just get on with the work and start helping people where we can. Because I can't think about all the societal causes of the issue. I can only deal with what's in front of me. Otherwise, I'm just going to collapse and die, because it's too much.
Yeah, thank you very much. I can also imagine, Dr. Gordon, it must be politicians, as Dr. Martha has said, but I think one can also say that the legislative, arm of our governance also seems to be coming, with a few answers. I mean, there's the family courts and there's the children's courts, and there's, avenues like this that, us as practitioners, we can equally empower and, inform, our patients, because whether we like it or not, we also deal with a wide spectrum of patients. And we also do have, unfortunately, illiterate patients who do not know about these, courts wherein they can go and cry, foul in cases of IPV. There's a question from Dr. Desai that asks, if a woman who is continuously being physically abused but refuses to report it to the police, what then becomes your duty? Or rather, the question is it our duty to report?
Yeah. Okay. So firstly, I want to take out the physical abuse aspect, because physical abuse, yes, is serious, but it's not the only serious form of abuse. Okay, we have to start thinking about IPV as a psychological crime. Otherwise, we're not going to ask the right questions. So if someone is being continually abused in whichever way, be it coercive control or economic or financial, and they don't exist as one form, they cluster. What the law says is that the only time you are required to report as a medical practitioner is if there is a child in front of you who is being abused, or there is an elder, someone older than 65 who's being abused, or if there's someone, for example, with an intellectual disability, so a vulnerable adult who is being abused. Under those conditions, you are mandated to report. But when it is an adult victim who is not intellectually disabled or an elder, then you do not report. You don't have, you are not compelled to report. And in fact, you shouldn't report, because remember, everything that happens once this abuse has been disclosed, everything that happens has to be victim-led. Otherwise, you continue to disempower. And you don't know what the risks are of going to report this and whatever. So you are not compelled to report, and you could actually make things worse if you try and do that. It's not your role. Your role is to empower the woman to take the next steps that she wants to take, and then support her if she wants to report. And that's fine. Then you do what you need to do, but we don't have the mandate, and we shouldn't report either.
All right, thank you very much. There is a question that comes from an anonymous writer. I think he's using a Galaxy tab, and the person is asking, I want to agree with Dr. Chivaugn. As a person working at a rape center, the men don't come forward. The men are abused a lot. The few who do present to our centers on the verge of death, we need to support men as well. So I think it's more a comment more than a question. It is, and I think.
Yeah. I'd like to respond to that, and again, I couldn't agree more. There was a research study that came out of our university, which anonymously asked children whether they were being sexually abused or not. And of course, everybody expected that it was going to be the girls who were being abused far more than the boys. But in actual fact, the boys were being raped and abused at a higher rate than the girls, because it's practically guaranteed silence. And so those boys who are being so badly traumatized go on to become perpetrators or victims, but very often they go on to become perpetrators. So absolutely, the conversation about intimate partner violence has to include men. It has to include what's happening to men, what they're enduring, and how they can deal with the pain that they experience. Because one of the big sort of drivers of IPV is that we live in a very patriarchal society in this country. And so men are not supposed to have emotions. You're not supposed to cry. You're not supposed to emote at all. And so where do you take out your frustration and your stress? It comes out in your fists and your words and the shouting and the insults and the abuse. So yes, the men in this country need to stand up to start supporting other men so that we can all support each other, because we have to do it together, and we do have to pay attention to the men. I absolutely agree with you. It just doesn't happen to be my area of specific expertise, but you're right. We can't exclude the men from this conversation.
Thank you very much, Dr. Gordon. And thank you once again for a very insightful, heartwarming, presentation. A presentation that, picks on us to think broadly and think more every time you are confronted with a patient that really appears like they are in a very difficult situation. And I think we have, overstayed our welcome with you. We are above 17 minutes, but we thank you very much once more for a wonderful presentation. And I would like to say, on behalf of Clinics Health Group, management, thank you very much for honoring our invitation and, making this presentation available. And to all the colleagues out there, this, particular presentation is a recorded presentation, and it will be, sent to you via a YouTube link, and in a day or two or so. And once again, kindly give us your feedback on the link that will also be sent to you in order for us to improve, this service offering of this particular platform. And we invite you once more next week, once more on Thursday, for yet another insightful presentation. On behalf of Clinics Health Group, the clinical team, and the marketing, team as well, led by Ms. Masondo, Dr. Gordon would like to thank you very much for a wonderful presentation, and good night, everybody.
Thank you, and happy birthday.
Thank you. I appreciate it.